Good morning, everyone. I think my work is not so hard, taking the intervention perspective in this debate. So, left main disease, we know it's represent the highest risk lesion of coronary artery disease, as it supplies 70% of the myocardium. That's why the current guidelines strongly recommend revascularization of patients with significant left main disease. If we look at the timeline of myocardial revascularization in left main, it started in 1973 with the first CABG that was later on proven that it is better than medical therapy in the CAS trial. Meanwhile, not very far from that date, the first PCI was done in 1977 by Dr. Andres, and it was later on tested with the introduction of per-metal stent in Lehman's trial that favored actually PCI to CABG, and subsequently with the introduction of the drug-eluting stent, which was again proven in the landmark trials of the Syntax and then pre-compact, followed by the latest trial of Axel and Noble trial. So if we look at in depth on these RCTs, you're going to find all the trials actually, starting from the Lehman's all the way to the largest RCT, which is Axel trial that enrolled around 1,900 patients. They have shown that PCI is actually not inferior to CABG, either at 5 years or even at 10 years in the Syntax and pre-compact trials. The only trial actually did not show the same outcome was a Noble trial. Otherwise, all the trials actually, even when they were tested in the meta-analysis, and mainly the 4 main landmark trials, it showed that the mortality is same. There is no significant difference between PCI and CABG in 5 years, and also in 10 years, the meta-analysis of both Syntax and the pre-compact trials showed there is no difference in all-cause mortality between CABG and the PCI. So it's very clear now that the interventionists actually, they are soaring and flying, and while the surgeon, they are still crawling in the evolution, because as we heard from our colleagues now, there is a lot of technology development in the intervention in terms of imaging, physiology, and of course, rotablation, as well as the learning curve of the skills in left main PCI. So actually, we need to focus on the real world, and we focus on actually what the patients actually care about and what they want. And we all know that the patients don't really want to go through all the complications and of CABG, and actually this was even tested, and they found that what we want as a physician as a survival, the patients also care about the stroke and MI, which has been proven by the meta-analysis that it is more in CABG, and also the physical activity and recovery is much better with PCI rather than CABG. That was also shown in the Axel trial. And that's actually what patients care about more. And we always tend to forget the other complication from CABG, like atrial fibrillation, cognitive decline, depression, and time to recovery that we rarely discuss with the patients actually, rather than the survival. So based on the Axel and the Noble trial, even the guidelines has been updated. If you look at the 2018 guidelines, it has upgraded from level of evidence P to level of evidence A. And the American actually, they have moved away from subclassifying the guidelines based on Syntax score. And that's actually what I like for the guidelines, because we know in real life, even if the patient has a high Syntax score, the surgeon, then they tend to refuse doing the surgery because of many reasons. Like the severe LV dysfunction, frailty, and so on. That's why, despite the guidelines, we still also need to think about what the heart team decide. And actually, it's not what I want or the surgeon want. Actually, it's what the patient want and what we can offer him as an outcome. Thank you very much.